Thank you very much again, and many thanks to EQuiP for giving me not only the privilege but the pleasure not to just meeting all the friends and being inspired from the work of your meetings, but also just to raise a very important European problem named financial crisis, and just exploring together to what extent the financial crisis is strongly related with the issues of equity, quality of care and patient safety. And also the 2 last days I was meeting with the European delegates across many European medical faculties. The main impression from the meeting is just even faculties or academicians have a limited knowledge about the strong impact on health and welfare that financial crisis has mainly on Greece, and secondly in some other European countries. I'm planning. Yes, please. Okay, fine. I'm planning not to just giving an academic talk, or not. Also, my aim is to illustrate the literature, and there are many papers, mainly on the Lancet, were just covering this issue, but just a little bit highlight some messages mostly relevant to EQuiP. And finally, upon your kind approval, I'm planning raising some issue with a potential impact on the job of this strong European VONCA network. Only for the introduction, 2 introductory slides, just a little bit saying that it's very well known before the austerity, before the financial crisis, that there are gaps in terms of the quality of care, either in terms of morbidity or mortality, even in the same country, even between rural and urban areas, even between northern Greece or southern Greece, even between mainland and island, but also between, particularly this divide between north and south, east and west. This was very, very clear for many WHO records. Of course, you are aware more than me that still there is a confusion on the terms they used even when discussing equity, and that's even in academic world there are certain confusion to what extent an equity or inequities could be discussed either at the level of equality of care or at the level of the healthcare provision. I'm certain that your network is dealing with all of this confusion about terms, but just I'm raising that even in this important period of austerity, that still there are differences in concept and definition, and we needed a little bit to teaching our politicians how we can deal on and they're using inappropriately the terms. This is one of the last paper of Lancet. The Lancet has published quite recently, 2013, a series of papers dealing with the financial crisis, and mainly with its effect on a European healthcare system. Mainly the work of Professor McKee from the Tropical Institute of the London School of Hygiene and Tropical Medicine, but with also European Observatory, which just dealing with this issue. And one important of this paper is just in the last sentences saying that public health voices remain largely silent. This is not my view coming from one of the countries mostly affected by crisis, but it was the voice of European colleagues. They saying still the voice is silent. That means we needed just raising the issue of a financial crisis and impact on equity, on quality of care and patient safety mostly, particularly for our data, from our experience, and using properly either to medication or to research. And this is from the same paper, with just a little bit addressing the impact on Greece, and just a little bit offering some information that now universal coverage, as a previous colleague that's underlined, is not an issue now in Greece, at least in Greece. Since now we have user fees, and that means the contact or the consultation with the primary care physicians is now almost impossible for at least for 20–25% of the entire Greek population. And in another paper, again from the same team, and also Marina Karanikolos and Steve Stagler in this team have enormous contribution. It's just saying that it's a failed experiment, that even the austerity that's trying to solve financial problems, there is not now such strong evidence that effective healthcare policies have been implemented, or just no any evidence that the health equity has been addressed by policies introduced in dealing with the financial crisis, and given a lot of even macro data, that is an issue that's requiring some methodological approach to what extent macro level data or experience, for instance, from Argentina could be translated into Greece. That, but of course we discuss it in one later slide. In a second paper from this series, this is one of the key messages. It's saying the East-West health divide is partly due to failures of health policies in Eastern Europe. I think that the colleagues in that just referring only Eastern Europe. But in my view, it was necessary in saying at least countries in Southern Europe also, included Greece and maybe other Southern European countries, because still there is a big debate to what extent general practice or in academia or in the clinical discipline does not follow the same pattern as in the Nordic countries or in Northern and Western. It's very important just to check in the capacity and the budget allocated to health or to research in Southern countries, in Eastern countries, in explain even partly the big East-West health divide. This is another from this series, we just given the inequity and inequalities in health services from children, and in general saying that the lack or the absence of chronic model was a key issue at this time, or in other words, the continuity of care, which is a lacking issue in general practice and in primary care in many Southern and Eastern European countries. Probably is more visible. Now is more visible after the financial crisis. I'll give you some example from our experience on Crete. This is enormous impact. This has enormous impact in the society coherence. In Greece and probably in another, we're having a very extreme right moves now. We just the major message is just removing immigrants. No any care for immigrants. No any care, not only health care, no any care for immigrants. That we have in a lot of conflicts at this time in Greece and I suppose in many other countries. And Mike and Tim stressing that even in countries with just immigrants before the crisis experience at least a healthier life or experience healthier indicators. Now, after the crisis, there is a trend that's given that the migrants now have been exposed in a very high insecurity and also just very vulnerable for communicable but also for non-communicable disease. And this is just a review from a WHO report that even before crisis with just making a focus on people poverty, poor education, deprivation, unemployment, job insecurity, and job stress, which is a key issue at this time in Greece, that they are very vulnerable for mental health disorders. But talking about, because just even years ago, myself, I was talking about the health promotion. Now what about the health promotion? That means nothing, no any chance at this time after financial crisis, just to raise in the issue of health, of disease prevention and health promotion. And since now almost zero of the Greek budget could be focused. Even this proportion was quite limited. According to WHO report, this is even lower. Just coming to Greece, not so spending so much time. This is from the macro level approach of Dr. Christos Lionis, another member of a EQuiP team. We just in this initially report talking about the Greek tragedy, just referring, it's almost an expectation and looking on macro level data, an increase on suicide rates, on violence. This is true and a very well experienced, and also on people seeking certificate sickness. Of course, there are many data. I'm not liking just spending your time. This is very important because the people from Troika expected that if we put in a barrier to the people going into primary care services and asking user charges, they expected that it will be reduced the demand and then the high consumption of healthcare services, and also reducing the cost allocated to health, which really before the crisis it was quite high. But nobody of them was thinking that putting this barrier was good for the poor, for the population having the most visible need, for the people having multimorbidity. And now unfortunately, people without any security, without any budget, family budget, that have been isolated entirely from the healthcare system, and that's expected only voluntary services to offer even basic services. There are a lot of issues, I think not spending much time in discussing about the suicide. I'm giving this slide because if we're looking in many other countries, of course the suicide rate is strongly related with financial crisis. To my view, it's difficult to translate the data from other countries because a health asset could be explained locally, and also there are many health assets even in the Greek population, including the family in the rural areas, including religiosity and spirituality in certain families. That means we need it carefully translated. This paper by Fundoulakis from the University of Thessalonica is just raising some comment that is quite early to say that the suicide rate has an enormous increase in Greece. This is only a few years data. I needed it more than 5 years in order to justify the first initial observation. That means rough numbers with just showing a pragmatic increase, but you needed further data to be more evident and secure. And support of Greece. I'm not just giving this paper, just saying, please, my colleagues, support the Greece. No, this is a slide mostly for the Greek colleagues and friends and secondary to the European Institute. This is published in the Science. It's a Nobelist colleague or researchers, and saying continually support of Greek participation in major European institutes. That means now the strong voice in Greece is please the politicians, do not stop the link with Europe. And also to the general practitioners, please join all the networks and raising your voice and working effectively with the European institutes and networks. About Greece, much discussion now paid on the effect of crisis, even in the issue of equity, and particularly in marginalized people, in the drug users, but justice an issue concern all. That's a very, very strong significance of HIV infection among the drug users, injected drug users. We have enormous data at this time. This paper is coming from the University of Athens and the National Center of Observing HIV. But also we have data that other communicable disease in Greece is not in this slide, and in this paper I'm just having the data from a Greek national report that malaria, hepatitis A, and many other infections which almost have been disappeared in the past now revisited Greece. And also in this paper by Manova saying that probably West Nile virus and a non-imported malaria and of course HIV could have in a relation with financial crisis. I think now we needed a little bit to raise the voice of primary care, and coming into the last almost part of my presentation. This is a paper that was just published before the crisis, just showing it to my European colleagues. That is the voice of primary care physicians. We're having an explorative study, quantitative and qualitative, and these are the results of qualitative study, when general practitioners, primary care physicians from two regions, Epirus and Crete, it was just interview, focus group and semi-structured interview will be used. And one of the main requests of GPs at this time is just before the crisis saying GP empowerment. They asking always just for the politicians to empower and increase in the capacity, and also they asking leadership reforms. They saying, please politicians, do something, change the old-fashioned Greek primary care system, and give the opportunity for multidisciplinary working. That means a voice raised even the financial crisis. This is our voice just before reading the Marina Kenda-Nicholas and Mackie report. This is the voice of the rural GPs affiliated to the University of Crete. We just explain in this letter to International Journal of Remote and Rural Health that the impact of financial crisis in the quality and the equity of the services they are offering, but mostly on the quality. They saying that no any time at this time for prevention. The Troika and the Greek government and asking just to introduce a computerized system, but only writing prescription. And this is also very old-fashioned, and now no any time left to any other activities to rural practitioners. They struggling, they complaining, they saying that we needed to have a more comprehensive view, not just to write in prescription, and that unfortunately at this time the financial crisis led to a different behavior of physicians, and also of course leading to a low performance. Just before the crisis, but even published in 2012 in the European Journal of General Practices, we publishing that the Greek families storing at their homes many medicine. This is also, of course, us when we observing and reporting as a failure of the effectiveness of general practice. Since there was a focus only on prescription, they write in medicine without explaining to the physicians, to the patients, and the patients they store in the medicine even with a limited use. And we identify that there was €1,000 almost in the family stories. This paper and our suggestion ideas has been utilized appropriately after the financial crisis. These the municipalities and the regions, particularly in Greece, but across, of course, Greece, they took this idea and just organized some voluntary services, asking patients to put their stories at the disposal of the regional and local authorities, and then classifying the medicine. And now some teams have been organized in recycling the medicine and giving at least 1/3 of the population without any access to medicine at this time. And this is, sorry, just only an illustration. We needed it in Greece now. Instead of rediscovering and reinvent wheel, it's just learning from the others. And just one example, one paper we just wrote, what Greece can learn from UK primary experience from empirical research. That means it's not necessary to ask in Troika or stupid politicians. Europe is plenty of ideas, plenty of good experiments, and plenty of best practice. And that we needed to learn. This is also a paper that has been accepted in the European Journal of General Practice. We're just trying to make a big review, which is the Greek response and what fundamental changes we needed, even in the university, even in domain of research, and particularly giving more focus on primary care and general practice. Of course, we needed, we can learn from a European perspective. This is a European FP7 project. We just having a coordinator in Ireland, in the University of Limerick, and also many universities across Europe, including Vienna and the University of Crete. We're just trying to see to what extent existing barriers in language or in access to primary care services could also be explored, and using and borrowing information, using sociological theories could translate it into action. And this is our very, very small reaction of the University of Crete. 3 years ago, upon the crisis, we decided to open a university primary care unit in collaboration with the municipality of Heraklion and under the support also of the University Hospital to offer services for the poor and underserved population of Crete. Of course, we choose 600 patients initially in teaching our students, because now in Greece there is a major request to change our curriculum, towards in teaching our medical students how to deliver effective care in people without any access to the services and without any budget, even buying and having the medicine. That's we have now we testing the general practice and testing the European definition of general practice, comprehensive review, holistic medicine, etc. Now are testing, particularly in people without having any access to primary care services. And of course, we needed a little bit to change our curriculum, not just giving more skills and guidance how to manage the people which are under financial restriction, but also just a little bit of change in the habits and the skills of our people. And we decided to introduce a course. We say in a course of compassionate care. I suppose it is a second course in Europe. As I know, there is a similar course in the University of Napier in Scotland, UK. And this enormous response by students with just a very interactive interface, and given the opportunity to visit patients without having any access to care, and patients, of course, with chronic illnesses, and the students are enjoying very much and expressing their disposal, even at a voluntary, to support compassionate care services. And of course, it's a chance for research, where now we're having more opportunities to study the so-called psychosocial determinants of chronic illnesses, And that's, we're looking further to study the religiosity and spirituality, to what extent it could be considered as a health asset. And this position paper by Boris and etc., by the World Federation of Public Health Associate, we just given some good position statements. I'm finished, it's almost at the end of almost half an hour. At the end of my slide, where just could read these statements. It's fantastic statements, but to my ears, looking a little bit rhetoric. And this is my suggestions, our suggestion. Of course, a suggestion, this is the last slide, to EQuiP, expected that EQuiP, having so much experience and expertise, should focus more on the impact on financial crisis and the impact of health. I'm strongly suggesting to all of you and to Executive Board, of course, just a position paper on that subject, in raising our voice, the voice of general practice. This is a suggestion a little bit coming from our local experience, to press health planners and politicians to consider equity in health when they're discussing sustainable development, when they're discussing with the Troika representative. Equity should be an issue. To facilitate the local and regional administrative authorities to implement their policies to alleviate the burden, we needed to convince and persuade the central government, please leave some freedom to the regional authorities, not always central statement, central directives, to support more integrated action, strengthening primary care and facilitate partnership. We needed integrated primary care, independently if the private and the public sector, independently if it's coming from the church or from the regional health authorities. To encourage academicians to undertake initiative for a medical curriculum with more social accountability and also a community orientation. Community orientation now is more visible. Not needed now robotic surgery, as the students now in the last week in the medical faculty, they were asking to plan an educational vocational program for residents to make capable in managing morbidity in poor population and compassion. I think that is my end. Thank you very much. Apologies for the passion, even before the crisis, always I have a passion in my voice. I'm thanking also EQuiP, the President and the Executive Board, but also